All right, everyone. We have a few more minutes. I got on a little bit early today, but I'm just going to go ahead and talk with you all a little bit about some of the cool things that we have here at Archer Review. We'll just take advantage of this time. And if you guys have any questions, go ahead and put them in the chat. I have our lovely Jada. She is a professor and works with nurse practitioner students and nursing students every day. So she is a wealth of knowledge. So if you have any questions, please take advantage. There is the QA. If you want to be anonymous, you can remain anonymous using the QA. And you can also just use the chat if you're okay just showing your name. But we really know that we get more out of these types of webinars and lectures when you guys participate. So please do everything you can to kind of put things down, focus, and get the most out of today's lecture and participate with us, just so you can really practice some of these questions and really feel prepared for your boards exam as it's coming up. Okay. Some cool things that we have, you probably know this if you tune into a bunch, but we started the SurePass Pro. This is really an awesome all-inclusive kind of package. It has the Q bank, the on-demand, and then we do what's called a live review session. The live review session is 3 days of everything you kind of need to know, just a brief kind of rundown of everything that you should know for your boards exam. And then you can kind of take that and go a little bit deeper into those topics using the on-demand and the Q banks. We also are offering mentoring or tutoring. And that's meant for somebody who might need just a little bit extra help on some areas that you know that you're struggling with. But also when you move out, once you pass your boards and you're now working, if you need any of that mentoring for interviewing, for once you're out in practice and you want to run some cases by somebody who's also in practice, all of the instructors, all of us are currently working as well as teaching. So please, if you have any hesitation, do that. But that SurePass Pro is a really great way to go ahead and prepare for your boards exam. We have so much content on our website with 16 hours, more than 16 hours of videos that you can watch at your own leisure. And then you can kind of click around to just bite-sized things. So say you want to just a refresher on EKGs, that's something you could go ahead and do that with. Um, Never enough practice questions. I just say at least 25. You should be doing at least 25 a day. Just to get ready. And then we have that readiness predictor, so it will kind of tell you where you're at. All right. And then you can join our community here. We have a Facebook group. We also are on Instagram and TikTok. I always tell people during all of my lectures, so I know there's some repeat for. So sorry for saying the same thing again. But if I misspeak, if there's anything that you're learning differently, if I'm not teaching you the most evidence-based practice, please let me know. You can email us at Nurse Practitioner Archer Review. We do try to stay up to date on everything as much as possible. But as you all know, modern medicine, it's just constantly changing. And sometimes we get a little bit behind, but you students know exactly what's going on here. Okay, so I am going to do what's called a Slido. And this is just an interactive tool to kind of participate, to get you guys to participate and really get the most out of this lecture. So if you haven't already, go ahead, take out your phones, scan this QR code, and let's get started. I am going to just kind of toggle back and forth here on my screen and let me know if this works. But if you can, go ahead and type in, let us know, where are you joining us from today? I love that everybody, we get so many people from so many different places. We have somebody from LA. Awesome. Nice weather out there, I hope. Mississippi, Florida, Colorado. That's where I am. Welcome, welcome. All right. Okay. And then our next question that I'm going to ask, who do we have in our audience today? Do we have RNs with the ADN, the BSN, LPNs, nurse practitioner students, or NPs? Go ahead and participate in that. Nurse practitioner student. Awesome, guys. So we have some people from kind of all over. Oh, more nurse practitioners. Awesome. Wonderful. Great. And I see that the Slido is working, and that's what we want. Just keep that on your phone today. We're going to go ahead and that's how we're going to answer some of the questions that I'm asking you. There's no, this is not about getting things right. It's about learning. So please, please, please participate with me. Okay. We are going to dive into our lecture and we're talking about gastroenterology today. We're going to start with the exam, and then we're going to go on and talk a little bit about GERD, peptic ulcer disease, and how we treat that stuff and things we need to look at. But before we go any further, let's just talk about our anatomy. So when we think about the abdomen, we divide our abdomen into four quadrants. We have our right upper, right lower, and left lower. This is just kind of our map. It helps us locate organs and describe findings accurately, okay? We can think about what lives in that quadrant and what could be affected. Now, it's not always the case, as we can have something called referred pain, where pain is actually being transmitted or felt in a different area, and it doesn't really resonate with what lives in that exact area because it's now referred to a different location. Okay, but let's just start with that anatomy. So in the right upper quadrant here, we have the liver and the gallbladder. These guys process our toxins, our fats, and then it has the stomach just nearby, right? The stomach is going to handle our food digestion in that small intestine, which it spans from those upper quadrants down into the right lower quadrant. The job of that small intestine is really to absorb our nutrients before handing off fecal matter to the large intestine. In the upper quadrants, we have the pancreas. That's really responsible for regulating blood sugar. Then we have our spleen over there towards the left, which is really important in immunity. Heading down to those lower quadrants, we have the sigmoid colon in that left lower quadrant, which is responsible for really moving stool through that last descending part of our bowel system. And then finally, in that white or in the right lower quadrant, we have the appendix, which we're not quite sure exactly what all it does. There's some evidence suggesting it has something to do with immunity, but we're not 100% sure. We know that it does cause some issues, especially in younger males, as it can get inflamed and infected and it can burst or perforate. So we want to make sure that we're always kind of have that in the back of our mind, which we would consider like a peritonitis or some sort of infection in that abdominal cavity. Okay, so we got that done. So now let's talk a little bit about our exam. There are four real major steps when we're doing an abdominal exam. Okay, and we do it in a little bit different um, uh, a different pattern than we normally do because of something really, really important. Do you know what it is? Why we do inspection, auscultation, then we percuss and palpate. Do you know why we're doing it in this exact order? Can anybody put in the chat? Why does it matter what order we do an exam? Any ideas? Exactly. Good job, Vincent. That's exactly the answer that I'm looking for. So we don't want to disrupt our bowel sounds. Our bowel sounds give us a lot of information. And if we start palpating and percussing before we listen, we may disrupt and we may actually cause those bowels to start moving when in fact they weren't moving at all. And it's going to really limit our exam and our accuracy in our findings, right? So really, really important that we do inspection, auscultation, percussion, and palpation and we go ahead and we move in that order. This is something you could see on the exam. All right, so when you're inspecting, you're going to just be looking. I always look kind of from the side with the patient lying supine and looking for just shape, movement, masses, skin changes, right? What are we seeing? Then we're going to go ahead and listen in each quadrant. With our stethoscope, normal sounds are going to be that low pitched kind of gurgling 2 to 5 sounds per minute. And then if we're hearing more than that 2 to 5 sounds per minute, we consider that to be a hyperactive bowel. And if we hear less than that, that's what we consider hypoactive. And then if we have no bowel sounds whatsoever, that would be considered absent bowel sounds. And that's when we think of things like an obstruction or something more serious going on if we don't hear anything at all. All right, then we're going to go ahead and move on to percussion. And I know a lot of people don't really learn this, and it might be a little bit of a lost art. I really, really encourage you to incorporate percussion into your exam. And I say do it on all of your healthy patients because it can give you some information when somebody does come in with abdominal pain when you're percussing. So when we percuss, we're tapping our finger. I just use my pointer finger and my middle finger, and then I'm tapping, making sure that I'm not suppressing any of the sounds with the rest of my hand. So it's just the finger that's touching the abdomen, tapping on top. So middle finger to middle finger is what I do. You can practice on your desk right now, but as you're moving around the abdomen, you're going to hear the sound change from something like more of a dull sound to more tympanic sound, so a higher pitched sound. So when you're moving, you know that you're getting over something that is dull. Then I would think of a mass or an organ or something like that. You have some sort of structure under there. However, when you start hearing more tympanic sounds or those higher pitched sounds, you're starting to think that you're over an air-filled structure. So maybe the intestines, right? And maybe somebody has a lot of gas in there. Or you can actually hear when you get to the stool of the intestines. So if there's a stool, a massive stool in there, when you're percussing, you might actually be able to pick that up. And so it's just an important, skill to use and perfect as it will continue to get easier and you're going to notice more things and it's going to give you more information. As a novice nurse practitioner, I don't expect you to feel like you can really get a lot out of this exam, but with more and more practice, you will learn more and it's worth keeping it into your routine. All right, and then palpation, we start with light pressure. We're kind of just looking for anything abnormal, and then we're going to go in and use more deep pressure pulse. Um, Feeling for that pulse along the abdominal aorta, looking for any sort of tenderness. If we see somebody who's really guarding and they're not ticklish, but they're guarding, you can tell the difference between somebody who's ticklish from your touch versus somebody who's in a lot of pain and they're guarding and they're saying, I don't really want you to be touching my abdomen because it hurts. In that case, we would consider some inflammatory process occurring, peritonitis, something a bit more concerning when we think about guarding. Okay, here's just one more slide that we think about. Again, it's inspection, then auscultation, percussion, and finally palpation. And we do that order specifically to not disrupt any bowel sounds. All right, now we're moving into GERD or gastroesophageal reflux disease. This is so, so common. You're going to see this a lot if you're working in the primary care setting. And you may actually see this in an ER or urgent care because if it's somebody's first experience with acid reflux, it can mimic something pretty severe. So, any ideas? What is something you want to rule out when somebody comes in with some GERD-like symptoms, some heartburn symptoms? Any ideas of what it is that we might be seeing? An MI, absolutely, or a triple. I love it. Good job. Way to go, you guys. Awesome. Exactly. So that's what I'm thinking about. So we want to make sure that we don't miss those things. They can look very, very similar. And that's why people do end up in the emergency room because they feel like they are having a heart attack. They're going to go ahead and get an EKG. Draw labs, look for any sort of cardiac enzymes. And if those all come back normal, then they'll go ahead and say like, hey, let's follow up with your primary or follow up with gastro, depending on the severity and get them the help they need. But do they really take care of GERD in the emergency room? Maybe a little famotidine, but that's probably it. So the rest is our job if we're working in the primary care setting. So when we think about GERD, we're thinking about a relaxation of that lower esophageal sphincter that is allowing gastric content back up into the esophagus. It can come all the way back up. It can actually come in and cause erosion in the teeth. I had a patient who had what we would consider silent GERD, whose dentist told him to come see me, his primary care provider, because he was having dental erosion related to acid reflux. So we went ahead and talked about these things. So first, we think about the risk factors associated with it. There's kind of a long list. But if you're over 50, if you have obesity, a hiatal hernia, if you smoke, if you're pregnant, that abdominal pressure, if you take a lot of NSAIDs, so ibuprofen, naproxen, stuff like that, And then your diet can be related. So we have all of these risk factors. Some of them are modifiable. So we want to first go ahead and take care of some of those modifiable risk factors, right? But we're thinking about people, do you eat lots of spicy foods? What time of day do you eat? Do you drink a lot of drinks containing caffeine, alcohol? All of those things seem to kind of contribute to GERD. And when we think about the symptoms, we think of things like heartburn, regurgitation, and like I said, some of those kind of more rare things like dental erosion, a cough, asthma, sore throat, even something like feeling stuck in your throat, that can be a symptom of GERD. So it can go a little bit beyond just that initial heartburn. All right, so when we're performing an exam on a patient who has just plain old GERD, we're not going to really find too much. We're going to really think a lot about kind of the history, and that's how we're going to get a lot of our information. There may be a little bit of epigastric tenderness, but not necessarily always. So there's no real true gold standard for diagnosing GERD. So again, it's a lot about just the history, making sure it's nothing else happening, right? Um, Making sure we don't miss any red flag signs or symptoms. So difficult or painful swallowing, feeling full really fast. If you're having those things, you're going to go ahead and get those guys out to for an EGD or an endoscopy so they can go ahead and make sure that we're not missing anything else. But we do want to do something about it. So, because if we leave GERD, if we leave this acid kind of without treating it, and that acid just continues to cause erosion, what can happen is what we consider Barrett's esophagus. So that's kind of a fancy term that we consider for cellular change in that esophagus that puts us at a precancerous state. So we do want to have those conversations with patients and making sure that we're treating it. Um, and we'll talk about just a moment how we go about treating it. So we talked about the risk factors, right, of somebody who has GERD, and we talked about some of those risk factors being modifiable. What that means is we can do a little bit of coaching, a little bit of motivational interviewing, and try to get patients on a little bit more of a healthful diet. Maybe talking a little bit about weight loss. Maybe we need to use a medication to help with weight loss. Talking about smoking cessation. Again, we may need to use a pharmacologic agent to help with those things, but those are modifiable risk factors that we can and we should be addressing when somebody comes in with GERD. All right. So, eating at least 3 hours before bedtime, avoiding those trigger foods, and then changing those modifiable risk factors. If your patient doesn't respond to those things, then we can consider medications, okay? We have two classes of medications that we prescribe. There are a lot of over-the-counter, as this is such a common thing. Most of your patients have already tried kind of the Tums and stuff like that. They're coming to you because those things aren't working, right? They may not have done some of these things, so it's good to always have that conversation and ask what medications they're taking. Um, the H2 blockers are, considered a antihistamine, and they work on the H2 receptor, and they work pretty quickly. So we think about the H2 blockers working faster, within 15 to 30 minutes. They may require multiple doses a day. And anytime we're thinking about antihistamines, we may have a central nervous system side effect. So we need to be cautious using this type of medication in elderly people. Doesn't mean a never, it just means be very cautious because of that central nervous system effect that they could possibly have. PPIs, I like to think of these guys as kind of like a little bit more intense for more intense presentation of GERD. And I think of all of the azoles. We have omeprazole, pantoprazole, lansoprazole, and those guys are going to work by inhibiting that proton pump and reduce the acid production. And that is a bind that will happen continuously. So it takes a little bit longer to work. Sometimes it can take a couple of weeks to have a full effect. But we really want to make sure that if somebody is not responding to the H2 blocker, or if they're elderly, this is something in our wheelhouse, and we want to help them quickly, so we can go ahead and do this. But when we think about prescribing PPIs long term, we do think of vitamin B12 deficiencies and osteoporosis. Okay, so the PPIs take a little longer to work, so you may need to use like a famotidine while you're waiting for the omeprazole or pantoprazole to really kick in if somebody's having pretty severe symptoms. All right. So if they're not responsive to our first line treatments, so we've done the lifestyle changes or we've talked about it, maybe we're successful, maybe not, but we've done those things. We've tried over the counter, they've tried over the counter medicine, no effect, and now we've prescribed and we're still not having any effect. That would be some time that we would consider referring somebody out to GI. For obese patients, maybe bariatric surgery could really help in relieving some of those GERD symptoms. There's also that niacin fundoplication. It's a procedure that essentially reinforces that lower esophageal sphincter and really stopping that reflux for good. Okay, so now I have a practice question for you guys. If you can pull out your Slido. So we have a nurse practitioner who's prescribing medication for a 77-year-old patient with GERD. Which of the following medications would be the best choice for first-line therapy? We have Pepto-Bismol, Tums, famotidine, or lansoprazole. Okay, so if we're 77 and we're diagnosing GERD, what is going to be our next best medication? And if you can, use your phone, get on there and answer for me. Okay. And again, I just put that question again up there so you can kind of see the answers. Lansoprazole, famotidine, okay. Anybody else want to take a shot? Pull your phone out. You can see that QR code here as well if you need to rescan in. Famotidine, okay, so we've got a 50-50 tie between an H2. An H2, do you guys remember what I said about an H2 blocker and the CNS effect, the central nervous system effect? So when we consider doing this, okay. All right, I think we got all the answers we're going to get here. Awesome. So the correct answer, you guys, is actually answer D. So we're going to use a PPI in an elderly patient. The reason why we stay away from that H2 blocker, and doesn't mean forever or always, but for a board exam question, very important to remember that that H2R can have a CNS effect on the central nervous system, can cause a little delirium. So we're going to be very cautious using something like that in an elderly patient because it can have a little bit more effect. And we want to be aggressive on treating this in a 77-year-old because of the risk factors associated with it. And that's why we're going to stay away from like Tums. It can be used kind of as needed. However, in this case, we're looking for something a little bit more aggressive. Okay. Just due to complications in an elderly person. Awesome. Okay, we're moving on to the peptic ulcer disease. So, peptic ulcers here, what we're thinking about is a little bit, I mean, similar concept as GERD. We're talking about gastric ulcer. However, when we're thinking about we're thinking about gastric acid, which is, the same thing that's causing the problem in the esophagus that's causing those GERD symptoms. Now we're talking about some mucosal erosion when we're talking about an ulceration, right? So now we have so much acid production that we're seeing that lining, that protective lining of the stomach or the duodenum is now kind of being eaten up by that acid. All right. And so we have, a different severity. We can get more severe erosion happening in which we could have a perforation. That's very, very scary. But, at the early signs, we're going to see something where we just have some early erosion in that first couple layers and are eroded, causing some pain. So, what are our most common kind of reasons for this? Well, first off, we think of that Helicobacter pylori or H. pylori. It's a common bacteria that is responsible for that PUD. It increases the risk of ulcers by kind of infiltrating that stomach lining, causing an over production of acid. And then we also think again of those folks, maybe they have osteoarthritis and they're taking a lot of ibuprofen because their joints hurt so bad. Maybe they have a history of alcohol use disorder, or nicotine, right? So any of those things are going to be risk factors for an ulceration. So how do we know where that ulceration is at? Is it in the duodenum or is it in the gastric area? Well, what's kind of cool and what's really great to know for the boards is that they kind of present a little bit different. So when we think about duodenal ulcers, those are the ulcers in that small intestine. They usually cause like a burning or gnawing pain that happens between the breastbone and the navel. Okay. So, right in this middle area, right here, epigastric area, it typically gets better after eating or after taking antacids. On the other side of the scope, when we have a gastric ulcer or stomach ulcers, they seem to get worse with eating, right? So the moment we put food into our mouth, all of a sudden that stomach is spitting out all of this acid to help us digest. So that pain gets worse when we're eating in the stomach. And it really intensifies about 2 to 3 hours after a meal. So ultimately, we're going to think about those things a little bit. So with, both types of ulcers, we may have these dyspeptic symptoms, nausea, bloating, feeling full, weight loss. You're not eating as much because it hurts to eat. Really big red flags we want to look out for, things like bloody stool, bloody vomit, severe abdominal pain. This would indicate a perforation, right? So now that ulceration, that erosion of the mucosa has happened so severely that now we have a GI bleed or a perforation happening. This is considered a medical emergency. You would send these folks, if you were suspicious for any sort of a GI bleed, they would not be staying in a primary care setting. They would be getting further workup. Okay, so remember when we talked about our exam findings for GERD, we didn't see too much happening there. However, when somebody has a peptic ulcer, we're going to see more severe pain, more of that epigastric tenderness when you're doing your exam. Again, looking for signs of a perforated ulcer, that would be intense epigastric pain, intense tenderness, tachycardia, abdominal rigidity. So you have that guarding, the abdomen is tight and tense, doesn't want anything to get there. Those things again, ER. All right. So we can use some of our diagnostic tools, that H. pylori breath test. However, when we are thinking about testing for H. pylori, we need to know what medications they have been on recently. We cannot test using a breath test for H. pylori if somebody is currently on a PPI, as it can give us a false negative, meaning that it would come back negative if we've suppressed their acid production using a PPI. So we have to take them off that PPI, wait at least 2 weeks, and then test for it or use stool sample or a biopsy if you're doing an EGD. Okay, so what do we do for treatment? Our goals really are to alleviate symptoms, heal that mucosal lining, and prevent any further complications. Our other intervention, why is this happening again? Is it something like, are they on steroids for something? Are they using a lot of ibuprofen? Is there those modifiable risk factors we can consider? Are there medications that are causing this? Is it that H. pylori? And if it is H. pylori, if we do get a breath test, then what we're going to do is go ahead and treat. So we have the triple therapy and we also have a quadruple therapy. The first line currently, the recommendation from GI is to use a quadruple therapy. So here we think treat my belly pain, and that is tetracycline, metronidazole, Pepto-Bismol or bismuth salt, and a PPI. Okay. If we use triple therapy, here we're saying pack that ulcer, like pack it with, like wound healing. So pack that ulcer, we would think of a PPI, amoxicillin, and clarithromycin. We could, if there was an allergy to amoxicillin, we could use metronidazole for that. However, quad therapy is the standard of care right now. And I just got an article released about that, saying that that's the preferred line of treatment at this point. Gauging for success, we're going to taper off that PPI. We're going to continue that PPI far beyond the antibiotic, probably another 2 to 4 weeks beyond, to really allow for that mucosal lining to heal all the way. So when we're thinking about testing for cure, I like to get a test of cure. However, patients usually are feeling so much better that they kind of sometimes don't come back until their annual exam. And then we're like, hey, how are you feeling? Maybe that's a good time to grab it. But what do we have to make sure? We have to make sure they're not on a PPI. So when I start somebody on a PPI for with the quadruple therapy, I'm going to go ahead and continue it for about 30 days, and then we're going to do a slow taper. So we might go to a lower dose, and then we go to every other day dosing, every 2 day dosing, and every week just kind of decreasing the amount, because what can happen with a PPI is what we call rebound acid reflux. So the moment if we were to just discontinue it all of a sudden, that patient will not be very happy with you, as they will not feel great. You can use something like an H2 blocker, so a famotidine, as you're tapering off for any breakthrough symptoms. Okay, if you're unsuccessful with your treatment, they did all of the quadruple therapy, had really good adherence, they took all of their antibiotics, those full 14 days, um, and you repeat their test of cure and they're still positive, then that would be a referral out to GI. Okay, another practice test question, guys. So we have a 54-year-old male patient reports recently being hospitalized for a perforated peptic ulcer. In addition, he reports frequent use of over-the-counter pain medication for osteoarthritis in his right knee. What pain medication may cause gastrointestinal perforation? What do we want to be extremely careful when we're prescribing to this type of a patient? So, if you haven't already, go ahead, join my Slido, and it should be up. Let me just take a quick look. Yes, there it is. And put in your answers. What medicine do you think? Ibuprofen 100%. Great. What else? Everybody's saying NSAIDs. Absolutely, you guys, really good. That's it. So NSAIDs do increase our risk for a GI bleed or a perforation. So we need to be very, very careful. So if we are prescribing something like ibuprofen, naproxen for somebody who may need it for a while, we want to consider using a PPI to protect their stomach from something like a perforation. So you may have a patient who's using this over the counter and you don't know. It's always good to ask when somebody does have an arthritic condition or a chronic pain condition, how are you treating it? You'll be surprised to find that a lot of patients take a lot of ibuprofen and they're not protecting their mucosal lining. So, the conversation always goes, can I use a different medication? Should we try Tylenol depending on their liver function? As needed, I like these topicals. I like diclofenac. It's topical, seems to be just a little bit safer for these types of folks. So are there alternatives? And if not, if they are, you know, hell bent on taking ibuprofen, then making sure we're protecting their GI lining. Okay, and so we got it. You guys did great. The answer was A. Okay. So, moving forward, we're going to just talk a little bit about some acute conditions, IBS, IBD. We're not going to get to hepatitis today. I switched it to put in a case study because hepatitis kind of takes a long time, and I think that's a lecture in and of itself. So, gastroenteritis, this is inflammation of the GI tract. We have viral, bacterial, or protozoal. Our most common viral things, norovirus. You guys hear it. It's so terrible. It's kind of what ruins your holiday, right? Everybody gets it. It's very, very contagious. It's fecal oral transmission. Here, we're going to see stomach pain, vomiting, maybe a little fever, watery diarrhea. Typically resolves on its own within 24 hours. Really intense for, and then it kind of always say All right. Sorry, guys. I'm not sure what just happened. My internet just went out, but I'm back up and running. Can you guys all hear me here? Sorry about that. Okay, good. Thanks. All right. Did you guys hear me talking about bacterial or did it cut out before then? Let's see here. Viral. Okay, sounds good. Okay, so bacterial, I think of bacterial, this is in the news, right? A lot lately. We have a lot of concern. Actually, it's not that I just heard this new article today. It's not so much that there's more salmonella or E. coli in our food. It's more so that our access to information and these organizations actually alerting people to infected products is just more prevalent. So we're doing a better job in our public health sector as far as announcing when things are going on versus us having like a bigger problem with our food supply, if that makes sense. Um, can you guys hear me? Okay, good. Okay. All right. Um, Anyway, so bacterial, again, we think a little bit about food that's undercooked or poor hygiene associated with that. So we know E. coli lives in the colon. So it can be, if, in the colon of cows and then you're transporting it and it infects the spinach because now we have feces that have come in contact and we maybe didn't wash it good enough. That is kind of what we think about. C. diff. C. diff lives in our colon. And oftentimes I think about if we prescribe somebody antibiotics, we now have, our normal flora in our GI system or that microbiome is that it's all off. So that good bacteria was keeping the C. diff in check, but then we gave a bunch of amoxiclavulanate, and now we've killed all of our good bacteria, and now that C. diff comes out at a rage. That's kind of that bloody diarrhea, cramping, stomach pain, fevers, might have like kind of more systemic symptoms when we're infected with a bacterial gastroenteritis. So I just think of a viral on steroids, just a little bit worse. Okay. Protozoal, I think the question that I always ask is, have you been around infected water recently, camping trips? Where have you been traveling? Anything like that? I think of Giardia, the Cryptosporidium are often common causes here. Here, when we think about this, I think of those sulfuric kind of gas or farts that people have when they have something like Giardia and the way that we see it. So, what do we do when we have somebody who is sick with a gastroenteritis? All right, if it's viral, mostly we're making sure that their hydration status is good. So we could do something like an at-home rehydration solution, oral rehydration solution. I worked down in the Amazon for a little bit of time, and we really worked a lot on oral rehydration. And the at-home one tends to be better. A lot of people love Pedialyte, but honestly, you can do this at home. So if you just look up a recipe, or you tell your patients, you can just look up a recipe. It's salt, sugar, water, maybe a banana or fruit, and you mix it up, and that's your oral rehydration solution. It's probably better for you than some of the stuff you can buy over the counter. But we want to make sure that a patient with a viral gastroenteritis is just maintaining hydration status. Obviously, if they are immunocompromised, if they are at risk of more severe infection, elderly patients, younger patients, those folks we're going to worry a little bit more about. Keep an eye on them. When we think about dehydration, the first thing I look at is their mucous membranes. Okay, that's where we're going to see it oftentimes first, then their pulse, blood pressure, all of those signs. Those are later signs of dehydration. Skin turgor, those are our ways to check somebody's hydration status. Now, if we think it's bacterial, then we can consider an antibiotic or oh my God, protozoal. So we would think of with the protozoa, I think of Flagyl because Flagyl has that little thing on it. Metronidazole is great. So if they've been camping or something like that, if we think they have some traveler's diarrhea, a Z-Pak is really great. We also use Cipro or fluoroquinolones for traveler's diarrhea, kind of getting towards that area. A lot of times we're just going to work through it. With C. diff, however, that's the vancomycin that we're going to be using. We can check, making sure that we're not missing anything more severe, but a lot of times this is just going to be kind of your conservative treatment. All right, so I love the abdominal exam, the Carnets test. This is one of my favorite tests. And let me just tell you a little bit about it. Okay, so the Carnets test is a tool for differentiating between visceral pain and abdominal wall pain. Okay, so visceral pain is our organs, right? So we think of the pancreas, we think of the colon, we think of the appendix, the liver, gallbladder, all of those things versus did somebody just kind of strain their abdominal wall, so the musculature of the abdomen? Were they doing sit-ups or something like that? And you're going to have patients who come in and they're going to say, I have this really bad pain, and this is a helpful test. So all you do is you have the patient like this woman in this photo is doing. You go ahead and have them bend their knees, and you're going to put pressure where the pain is, okay? And then you're going to have them engage their abdominal wall. So, like doing a little bit of a sit up. And when they engage that abdominal wall, if in fact the pain gets worse, it's indicative that that is a musculoskeletal issue, okay? So, when you have a sore muscle, I'm pushing on it, and now you start engaging it further, it's going to hurt a little bit worse. All right. If you have the pain gets better, um, what we think about is as we engage that musculature, that abdominal wall, we are now protecting whatever hurts underneath. Okay, so when you engage that abdominal wall, we have this protection. And maybe let's say it was your colon, your sigmoid colon is inflamed. And so when I'm pushing on that sigmoid colon, and I'm just pushing really, really, with a lot of pressure into it, and that hurts. And then you flex and you protect that colon with an abdominal wall engagement. And now that pain doesn't seem to be as bad. Then I think it's more visceral. Okay, so this is something I use in my practice a lot to kind of differentiate where it is. And you may have equivocal findings where you're like, well, it doesn't really get better or worse. Then we have to like use some other information. Okay, cholecystitis. This is inflammation of the gallbladder, often caused by like gallstones or blocking of that cystic duct. We think of risk factors being female, over 40, obesity, pregnancy, history of diabetes, or rapid weight loss. I think of those GLP-1 receptor agonists as a risk factor. So when people lose weight pretty quickly, they can get those little gallstones forming in there. We think of right upper quadrant pain, bloating, worse after they eat something greasy, spicy, fatty. Other things we could see: vomiting, nausea, gas, pain that radiates back to that shoulder blade, the right shoulder blade. That's kind of that referred pain. Okay. Serious symptoms. I haven't seen this, but it's jaundice, clay colored stool. You may see fevers and chills. Okay. So when we are suspicious for cholecystitis, we're going to be performing the Murphy sign. Okay, so that's when we have them do a deep inhale. And as they're inhaling, we are palpating that right upper quadrant. And pain during this confirms our suspicion, right? So now we think, okay, positive Murphy sign. I need to get some more information. We're going to do some blood tests. We may see an elevated white count. We may see an elevated liver function test. So ALT, AST might go up. And we're going to get an ultrasound or a CT to confirm our diagnosis. To kind of help us understand exactly what's going on. Treatment might be something like a bile acid medication like ursodiol or low fat, just kind of changing some depending on their presentation. Can we get away with lifestyle changes? Can we break those up with that shockwave lithotripsy? So with the ultrasound shockwaves to kind of break those stones up, or do we need to remove the gallbladder entirely? So that's kind of going to be what we see. All right, I'm going to skip this practice question, but we have a 35-year-old female. She presents, vital signs are here. Um, and we just talked about it. The answer, you guys, is going to be that positive Murphy sign. Okay, so I'm going to keep going just in the sake of time, but we want to make sure that you don't confuse McMurray and Murphy's. Those are the two that are most commonly confused. McMurray is meniscus, MM, and then I just remember the third M, meniscus, okay? Murphy's test, yeah, I don't have a great way to remember it other than just Murphy's is not the same as McMurray's, okay? So just make sure you know that as a special test that we can do. All right, pancreatitis. When we think of pancreatitis, we're thinking inflammation of the pancreas. It can mimic the cholecystitis in presentation. Okay, so a lot of similar things. And our risk factors include a history of gallstones. I always think of somebody who has maybe come off of a binge after a lot of excessive alcohol use. We can also see this with high triglycerides. If somebody has triglycerides over 500 and we start them on a GLP-1, this can increase the risk of a pancreatitis. Any sort of abdominal trauma, certain medications can also increase our risk. But what we're going to see here is some sharp upper left or epigastric pain, especially after eating or drinking, nausea, vomiting, fevers. These guys look sick, okay? We have the colon sign, which is that umbilical bruising, or the Gray Turner, which is flank bruising. Those are pretty specific for pancreatitis. We can see them in other things, but something to consider. If you see abdominal bruising in any way, shape, or form, I would say go ahead and refer that patient to the emergency room. Bruising on the abdomen is never normal. Okay. When we're considering this, they don't have bruising, we're grabbing a lipase and amylase, we would see elevations in both of those. Okay. Maybe an elevated BUN. Hematocrit levels might also be high, which would be indicative of a pancreatitis occurring. We would get something like a CT or an MRI to confirm our diagnosis. So, what is the treatment? Guys, we just put these guys on lactated ringers, take them, kind of NPO, and on LR just initially. This is in the hospital, obviously. We're not treating these guys outpatient. Um, and that's really going to be our biggest role. We may see a little bit of therapy working on getting those triglycerides down if we think that's causing it, or treating an alcohol use disorder if that's also the case. So a medication that I really like for alcohol use disorder is naltrexone or Vivitrol. It does seem to really help kind of slowly decrease use over time. Again, if somebody has alcohol use disorder, we don't want to just discontinue treatment or discontinue use as it can precipitate something like the DTs. Okay, diverticulitis. So diverticulitis is so common. Diverticula are these out pouches in our colon, okay? And when they become inflamed, we call it diverticulitis. So you might see on a report on a colonoscopy that somebody has diverticula. Note that in their record if you're their primary care provider, because if they come in and they have some pain in their abdomen and you know that they already have diverticula, it helps you get closer to your diagnosis of diverticulitis if it's already written there, right? So you know their colonoscopy shows us that they have this. As a risk factor for developing a diverticulitis. What causes diverticulitis? We used to think it was like seeds and nuts and stuff like that getting stuck in that diverticula. Now we think it's more of just bowel content or fecal matter that's getting stuck in there and causing some inflammation, which would be the diverticulitis. All right, so risk factors again, age. The older we grow, the more likely we are to have diverticula in our colon. Most likely that descending colon, but it can occur in different parts of the colon. Okay, so that whole large intestine. Low fiber diet, high fat diet, obesity, again, smoking, NSAID use. I would guess alcohol use goes along here as well. We're gonna see somebody present with some abdominal tenderness. You may or may not feel a mass. Maybe some hypo or hyperactive bowel sounds. You might have absent bowel sounds if now we have an obstruction, but you might have a partial obstruction because of the inflammation happening in an area of the bowel. Um, Red flag, signs of shock. We think of hypotension, tachycardia, really severe abdominal tenderness, guarding rigidity. That patient looks very, very ill. go ahead and work them up, you would consider getting a CBC. On the CBC, you'd see something like a white count, that elevated elevation in your white count, an elevated ESR CRP, so that's the inflammatory marker. And the CT is pretty common, what we would order. An ultrasound or a CT. MRI wouldn't be terribly wrong either. CT is just quick, cheaper. And we would see a thickened bowel on CT. Okay. So treatment here is kind of going in and out. So depending on what you see, you may or may not consider an antibiotic. Um, if they are unstable, they're going inpatient, okay? If they're in your primary care office, you know they have diverticula. This pain hasn't been present for very long, but they came in right away. They're pretty stable. Vital signs are stable. They don't have a ton of rigidity or something like that. You could just put them onto a clear liquid, watch, do some pain management, watch them carefully. But if they have any sort of immunocompromised state, you might want to consider adding that antibiotic. If they have comorbidities that put them at risk for severe infection, if they were to have systemic symptoms, that would be an emergency room. Okay. Appendicitis, you guys know this one. This is just kind of that like do not miss type thing. I think of young males. So for example, my son came home. He's 11. He came home from soccer one day, didn't play soccer all day, and was telling me that his stomach hurt. And when he pointed right to the umbilicus. First thing I thought, oh goodness, we're at the early stages of appendicitis. Luckily, he was fine. It was just probably some constipation. But that's what I'm thinking about. A young boy typically, and it starts oftentimes in that umbilicus area, and then it moves over into that right side, and it's inflammation of the appendix. We would see somebody with severe guarding. These guys look sick, fever, nausea, vomiting, loss of appetite. They just don't feel good. Okay. We can do our special test, which we'll go over here in just a minute. But in order to confirm this, we're going to think about going ahead and getting a CT or ultrasound on this patient. Okay. Also, a white count would show us a suspicion for some inflammation happening or infectious process, right? So we have our different tests here. So we have the Bloomberg sign, we have the SOAS sign, the Rosvig sign, obturator sign, the Markle test. This one is super, super easy to perform because you just have them go up on their tippy toes and when they drop down, it hurts. And this is like if you have a little kiddo, not kiddo, but like if you have a child, a pediatric patient, let's say, who is really nervous about you getting anywhere near this, which is in itself kind of a telltale sign, you can have them go ahead and start with this. And if it hurts for them to come down onto their heels, that's very suspicious. I would probably go ahead and get some testing done if that is causing them some stuff. And then you look at them and they are ill appearing. But go ahead, write down these tests. It's so important that you know these different tests for your boards exam and use these tests. If you have, one or two positives, that can be indicative that something else is going on. Again, with like the history and thinking it all the way through. All right, guys. I'm going to let you vote really quickly. Would you prefer a case study or would you prefer talking about IBS and IBD? Because we only have 9 minutes left. What, any ideas? I'm letting whoever answers the first couple in the chat. Do you want to go to a case study? IBS and IBD. Okay. Okay, we're getting a little bit of both. I'm going to try my best to get through both, okay? All right, IBS. IBS, this is a clinical diagnosis. What does that mean? That means, a diagnosis of exclusion, I should say. So that means we rule out everything else and we can't really figure out what exactly is happening. So we have this functional diagnosis, which is IBS. We use the Rome 4 criteria to do this. What I'm going to consider ordering is to make sure that somebody doesn't have something like a celiac disease or an inflammatory bowel disease. So looking at elevation in their the C-reactive protein or ESR would help, but we're gonna get this by seeing like, okay, um, They meet the Rome 4 criteria and they don't have any of these other things happening. So, what we think about is abdominal pain or discomfort, changes in bowel habits. So, these folks will go from like constipation to diarrhea, diarrhea to constipation. They may live in more of a constipative state or more in a diarrheal state, but they just seem to have some like pretty on irregular bowel habits. Um, and we don't really know what causes it, but we definitely think things like stress or GI infections, women tend to be more prone to this. So we just think of like a stressed out female patient complains of new onset abdominal pain. Here, we're starting to think a little bit about what's going on. So we're going to ask questions around her diet, stress levels, recent travel, symptoms specific, including like relationship to eating, stool characteristics, asking about red flags, like any bloody stools, weight loss, mucus in the stool, right? We're going to think about all of those things that would really cue us to something else going on in the body. Um, and then in the absence of those red flags, we again are going to do the IBS diagnosis based on the Rome 4 criteria, recurrent abdominal pain at least once a week, along with two of the following, either pain linked to defecation, stool frequency change, or stool parent appearance change. And then we think about our treatments. I really like the FODMAP diet. I don't keep people on a FODMAP diet. It's impossible to maintain. Well, some people can maintain it, but it's hard to maintain. So what I think about with the FODMAP diet is I say we go to this really bland diet where we decrease, we go to that full diet, kind of throw out some of these really inflammatory type foods, and then we go ahead one by one, add them back in, and see if there's anything in particular that's causing the IBS to kind of flare up. We can do fiber supplements or laxatives as needed. I don't want somebody to take those all the time. I love probiotics, just reestablishing that normal flora. I say buy the probiotics. I have a really good friend who is a naturopath, and she told me buy the probiotics that are stored at the refrigerated section of a natural food store, not the ones that are shelf stable, seem to just be more effective, or just eat things that are high in probiotic type things. So I think of foods such as like our fermented foods. So kimchi, yogurts, kombuchas, stuff like that can really help reset that normal flora, and then avoiding foods that cause the problems. There are different types of medications that we can consider. If you can't get this under control, GI is always there for a backup. Now, IBD is different from IBS. IBD, we have a autoimmune condition that's causing inflammation that we can test and see. Okay. So we're going to make sure that we're ruling this out, right? With just some simple things like we can do blood tests and make sure that we're not missing something here. But if somebody has an elevated inflammation marker like CRP, ESR, I would consider doing something like a colonoscopy or sending them to GI to get some further workup if their labs are showing something else going on. Crohn's disease, that can happen anywhere in the GI tract. We think of strictures, we think of inflammation, we think of skip lesions when we're thinking of Crohn's disease. Again, anywhere in that GI tract. We think of non-bloody diarrhea. We think of weight loss. These folks look pretty thin, oftentimes because their body's not absorbing foods quite right. Nausea, vomiting, non-bloody diarrhea with that Crohn's disease, again, anywhere in the GI tract. Ulcerative colitis is in the colon. It starts in the rectum and works its way up. Okay, so we see ulcers in that mucosal lining. We see bloody diarrhea with mucus. So that's one red flag, right? If somebody has bloody diarrhea with mucus, we're thinking UC. If we're just non-bloody diarrhea, we could think more of that Crohn's. All right, left lower quadrant pain as it starts in that rectum and works its way up. And then tenesmus. Tenesmus is that sensation that you need to evacuate your bowel after you've already evacuated it. So it just that strain continues. You're like, okay, I just had a bowel movement, but it feels like I didn't completely empty it, and you might keep straining. I think of, it's kind of TMI, but a dog. I don't know. I feel like dogs always have tenesmus. I have a dog, and I feel like I always think about ulcerative colitis when I'm walking the dog. Sorry, TMI. Just something to help you remember for your boards exam. Okay. What we want to watch out for is that toxic Mary colon. That's abdominal distension, fever, severe pain. These guys look very, very ill. If anybody's at your desk and or at, in your clinic and they're looking really ill, just trust your gut and get them out. We're going to use different medications to get this autoimmune disease in control. Okay. So, like I said, we're going to, you're going to check for laboratory value changes. We're going to use an endoscopy or colonoscopy to help us with diagnosis with the biopsy. That's going to be how we diagnose these guys. Okay. And then the medications, again, we're trying to put this into a remissive state. So we use those anti-TNF agents. Those are very, very helpful. Humira is one to kind of get people down. But then we always think about autoimmune. When we're suppressing that immune system, we're also at risk for other complications with that. Okay, very, very quickly, we'll just get through this case study real quick. Guys, go ahead and pull out your phones and um, let's go to the next poll question. Okay, not that one. Okay, so with this case study, we have a 62-year-old male. He's got a medical history of hypertension, obesity, hyperlipidemia, pre-diabetes. He does not have diabetes. He's on high lisinopryl hydrochlorothiazide. He's on semaglutide for the obesity and the pre-diabetes. He's also on a rosuvastatin 10 milligrams. He presents to your office with a sudden onset left lower quadrant pain, constant. It's worsening 8 out of 10. He's treating it with ibuprofen, 800 milligrams, 3 times a day without much relief. Temperature, he's got a fever. His heart rate, not technically tachycardic, but it's getting up there. Respiratory rate's good. OSAT's good. Blood pressure mildly elevated. I think because his pain, he's otherwise has good blood pressure control. He's got a little bit of that abdominal rigidity guarding, hypoactive bowel sounds in that left lower quadrant, some nausea, some constipation. He's passing gas, but just feels kind of constipated last couple of days. All right. I want you to throw out every single answer that you can think of what is on your differential. Diverticulitis, good job. What else? Just keep thinking your differential. So this is just anything that comes to mind. Throw them out there. IBS, IBD, awesome. Keep going. What else could this be? What is on our differential? Some some scary things can be IBD, good. What else? What else? Crohn's. Yep, good. Anything else? Constipation could just be some pretty severe constipation, cholecystitis. Love it. What else? What else happens in our abdomen? What other things could be going on? What about some referred pain? H. pylori. Oh, yep. I'll push you back to the case study real quick. I wish there was a way. I wonder here. I'm gonna see if this works. Can you guys see both screens at the same time? Yes, you can. Awesome. Okay. All right. Pancreatitis. I love it. You guys really good. Those are all the things. What's something really scary? Like maybe not scary, but what is the big word that nobody wants to hear that we should always be thinking about cancer? Yeah, what kind of cancer specifically would you think about there? Tumor, yep. Anything? Colon cancer. Perfect. That's what I was looking for. We just want to make sure we're ruling that out. Okay. Good work. Okay, so now differential diagnosis. So what I came up with, diverticulitis, IBS, IBD, colorectal cancer, acute appendicitis, bowel obstruction. I don't know if I saw that on there. Pancreatitis, ischemic colitis. Another thing, nephrolithiasis, kidney stones. Okay, so that could refer down to that left lower. Might present a little bit differently, but something just to keep in mind. Okay, so then things that we would order. Um, me come over to this. Let's see here. Okay, what would you consider ordering? What labs and imaging? So if this is your differential, what just throw out different tests that you might order. Any ideas? Some different tests that are helpful in this diagnosis. A CBC, absolutely. We're looking for a white count here. Also, just a hematocrit, make sure that we're not like having any GI bleed or something like that. C. diff, love it. Good. We're looking for an infectious thing. Okay, so maybe a stool culture, stool sample, H. pylori testing. Awesome. Really good. Anything else that you might consider ordering? Think about your imaging. So these are all labs, which is awesome. Colonoscopy, great. Could get like an MRI, CT, okay. Maybe an X-ray, EEG, EKG maybe. BUN creatinine, like it. Yep, definitely want to know their liver, kidney function, their electrolytes, barium swallow. Awesome. Yeah, these are all good things. Anything else that comes to mind? So look at our differential diagnosis list. STD workup. Oh, awesome. Really good thought. I like it. Yeah. Cancer markers. Okay. Like it. Some things I'm thinking about amylase and lipase, I would think about because of a pancreatitis, possibly. I want to see what those look like. Really good, you guys. You guys are awesome. Okay. Okay, so our results in this patient came back. We had an ESR of 70, a white count 15,500. Our CT scan showed localized bowel wall thickening greater than 4 millimeters. Oops, spelling error, sorry. Increase in soft tissue density, secondary to inflammation, presence of diverticula, no abscess, and no perforation. Good. So seems like pretty decent. Here we have our indications for hospital admission. Okay. So when we're in a primary care or an urgent care or a ER, here are the folks we're going to consider admitting or sending off. Okay. So this I just pulled from Up to Date. It's a really great, quick way to look at it, depending on what they look like. All right. If we are super, super worried about some of these things, we would consider sending this person to the emergency room. All right. In this case, we're considering him uncomplicated. He's only had this for a day. We know he has diverticula because we saw it on his colonoscopy. We're going to go ahead and do pain management for this guy. We're going to talk to him about just doing a liquid diet for 5 to 7 days. I would bring him back in, 2 to 3 days just to get eyes on him, depending on if he is. Let's say this guy's super, super healthy. He's reliable. He has a partner at home to help take care of him. Um, doesn't look that ill appearing, okay? Then we can go ahead and and just do these things. Antibiotics is not always anymore. It used to be the cornerstone for treating diverticulitis was always antibiotics. They are now not recommending antibiotics, but we would use something like amoxicillin, clavulanate, or Cipro, levofloxacin, or Bactrim, depending if they had some of these things. With this guy, I would maybe consider some systemic antibiotics because he has some systemic disturbances, right? He does have a fever. He's looking pretty ill. So I would go ahead and put him on a clear liquid, prescribe a little amoxiclav, um, rest hydration status, see you back in 2 days, sooner if needed, ER precautions always, and see how things go. All right, follow up within 1 week. You want to see this person back if you do an outpatient. If you send him to the hospital, then we would want to reevaluate within a week of discharge. Um, Dietary changes, talking about high fiber diet, super, super important. We no longer say you have to avoid nuts and seeds and all that because we don't think that's what's actually the culprit any longer. We will talk about avoiding chronic or excessive use of NSAIDs or aspirins unless really needed. Weight loss, he's already on a medication for weight loss, so we're on the right track there. We could consider colonoscopy 6 to 8 weeks after resolution of symptoms. We don't want to do a colonoscopy too soon after diverticulitis because of the risk of perforation. So when we are, putting a camera in the colon, if there is an inflammatory process happening at that time, that person would be at greater risk of a perforation from just a standard colonoscopy. So definitely want to put it out at least 6 to 8 weeks after complete resolution of symptoms. And then if this person's having a lot of recurrence or they're having a complicated episode or something like that, we would go ahead and refer them to GI. Um, they may be getting a medication or actual colon resection for something like diverticulitis. Okay, so they might take out a section of the bowel where there's a lot of those diverticula, would be something that we may see. Questions about that case? All right, and then we just like to get a quick final Slido 0 to 10, or sorry, 0 to 5 rating on how you like today's webinar. This is completely anonymous. I don't know who you are, but if you could just go ahead and give us a quick rating. And then if you haven't already, please sign up for some of the cool offerings we have here at Archer Review. We have SurePass Plus, or the SurePass Pro, which is a great, great product to help you feel ready for your exam if you're coming up. Oh, awesome, Vincent. You're the best. Thank you so much, guys. I really appreciate it. I hope you got something out of today's lecture. We will see you back after the holidays. I think that we're kind of everybody. I know I'm taking a little bit of a break over the holidays just to spend time with my family. I wish you all a very, very happy holiday season and good luck studying if that's what you're doing. Take some breaks, enjoy your you know, time off of school if that's where you're at. Really appreciate it. Okay, testing in 2 weeks. Yes, you're gonna do great. Next week. Okay, wonderful. Well, best of luck to you. You're gonna do great. Just remember, safest, smartest answer. Okay, the safest thing is always what we're gonna go for when you're answering these questions. You have this information in your head. You know these things. Okay, so just deep breath. Good luck. Happy holidays, everyone, and take care. Until next year. See ya.